Good morning, everybody. Thank you very much, Ben. It's my pleasure to share this day and with Dr. Clement Adebayo and to chair this session with Bob Carson. After those introductions, you understand how the University of Seattle has created, I guess, a department of global health or global medicine for Ben Anderson. Great. And Dr. Wiafi will be given a doctorate degree in global health also. Wonderful. We'll start the day. We are already late, Ben, as you know, so don't blame us. We will start our session on multidisciplinary teamwork and quality of care. The first speaker is going to be Dr. Raj Badwe. Dr. Badwe is professor of surgery and director of Tata Memorial Hospital. He has published and edited extensively on breast cancer, and he is member of our steering committee, and he will be talking on optimizing quality in breast cancer surgery and anesthesia. Dr. Badwe.
Thank you, Dr. Al-Sakir, and I must thank Dr. Ben Anderson for this excellent meeting that he comes up with, and every year down the line I find that it is getting better and better. What I'm going to give you is an insight into what have we done in optimizing quality of breast cancer care in India. And primarily the problem is uniformly delivering the kind of care that is considered as standard. So as early as 1992 and 93, we evolved a easily implementable classification of putting patients into categories. And these categories essentially were based on what kind of treatment plan each of these categories would go into. So here is easily implementable practices that we started off with. We then looked at what is the quality of surgery or quality of referrals that we get across the country. And we are privileged at Tata Memorial Hospital to see patients across the country. Approximately 40,000 new cancer patients are registered in my hospital across India. And we get a bit of input into what is happening in each part of India, as well as we also have access to the latest technology which allows us to test, is this technology implementable in our own situation? And we then try and see if we could provide some novel techniques which could be implementable in our own situation. So here is the first thing that we did as early as in early 90s of dividing. We do know that there are multitudes of classifications, and the standard one is the TNM classification. And we do utilize these classifications very effectively. But what we have done is assume that a group of patients require surgery as the primary treatment and adjuvant therapy to follow. A group of patients that, depending upon whether patient desires breast conservation or not, some of these 3 or 5 centimeters might fall in this category too. But it could be either surgery followed by adjuvant or first adjuvant followed by surgery. So this is a group that should receive the kind of chronology was left to the clinicians. This is a group that essentially could not be treated by surgery first, required some neoadjuvant therapy, and this is a group that essentially is palliative care. So this kind of a classification was introduced, was discussed across in all the meetings, and we then looked at how to what extent can we then rely that none of these patients or none of these patients get surgery per primum, or very few of these would get either primary radiotherapy or primary surgery or primary medical chemotherapy as the first treatment. And we then looked at to what extent. It probably took almost 5 to 7 years for this to be well accepted across the country. But today, a great majority of the patients would have the kind of treatment and the chronology of treatment that is really required for this group of individuals. The second aspect, as we reviewed what's the kind of referrals we get, we found that it was not always possible that the treatment that was given was appropriate. It required a second look surgery. It required completion surgery. And that, when we looked at the 148 patients that had earlier undergone surgery, which the treating surgeon had mentioned that it was a modified radical mastectomy, but in reality had just an incomplete excision with lots of residual breast tissue or an incomplete axillary dissection. In only half of them, just over half, had adequate surgical intervention. As an aftermath of this, we then put up on our website the standard of care, what was expected out of a surgeon in performing a modified radical mastectomy or a complete axillary dissection for, say, a diagnostic duct excision or a microducectomy procedure, as well as an advanced training, it could be a larger excision of the breast with a latissimus dorsi flap excision. So these 4 procedures were put up on the website for anybody to download and look at. And subsequently, when we looked at our data of 1984 to 1994, in those 10 years, approximately 30% of the individuals came with inadequate surgical intervention. And when I look at my last 2 years' data, which is after having introduced these procedures, after having conducted twice a year hands-on training programs for medical students who are finishing their surgical career, as well as those who are practicing surgery, to understand what is the extent appropriate surgery as far as breast cancer is concerned, we find that these referrals have gone down to under 8% of the amount of inadequate surgical intervention performed. So essentially optimizing how best the surgeons could do their job appropriately. We are also faced with the second bit. The part of this discussion was that the axillary dissection was inadequate. I must say that although at Tata Hospital we might be seeing an average tumor size of 2.5 and 3 centimeters, across the country that's not the case. 70% of the individuals would be 5 centimeter tumors or anywhere between 3 to 7 centimeter tumors. And that patient is in no way eligible for the kind of guidelines which are available from the West. That should I be doing a limited axillary dissection? Should I be doing only a sentinel node biopsy? These kinds of procedures are not possible to be thought of. Although once the technology comes in the market, it's difficult that it